well-informed and very, very engaging talk on diabetes, on insulin. Now I'm going to give you one very strong message. For the last 15 years, I've been speaking about this, but unfortunately, my voice is still not being heard. And the message is that type 2 diabetes is a surgical disease, right? It is correctable. Both it is preventable as well as correctable by surgery. But despite the last 15 years, the referral of bariatric cases to a bariatric surgeon or for diabetes are less than 5% of the total, right? So we are still not able to understand why it's happening, right? So let's see why it's happening. I think what I believe is it's not basically the lack of education. It's our belief that surgery is probably a very aggressive mode of treatment and probably it should not be done. But I will give you data to prove that this is wrong, right? We should go over the data. So we know all that the obesity is a world over problem, but today I'm going to talk about the diabetes. So about 9.4% of US population is diabetic. And if you see the studies from Pakistan, about 27% of our population is also diabetic. But the problem is that 1/3 of these people, right, they do not know they have diabetes. So there is another population which probably are not aware that they have that. And that's why they will come very late. And look at the complications associated with diabetes. You have end organ damage to every organ, the retina, right, and visual loss and coronary artery disease. But the biggest thing which I'm interested in is that 90% of these diabetics are obese. And when you are obese, not only you are prone to diabetes, but also to hypertension, to hyperlipidemia, and other comorbidities, right? So if you treat obesity, the advantage is you treat comorbidities at the same time. So 1 in 5 or 1 in 6 or so many advantages. एक ही टिकट में कितने सारे मजे उसके साथ. So these days, we are basically staging the obesity, right? And that's why I use this advanced staging system, right? Just like cancer, we have stages. Similarly, we define obesity as ABCD, right? American Association of Clinical Endocrinologists, they define it as an ABCD. ABCD means adiposity-based chronic disease. It's no more a risk factor, it is a disease. So stage-wise, you see the red stages. Don't let your patient come to a red stage. As I mentioned in my message, metabolic surgery should be used for both prevention and treatment of diabetes. So if you act previously before the patient has developed diabetes, this will have a far-reaching effect on the patient's management. Now, since we have a mixed gathering, I will just not go into detail of this, how do we develop diabetes. There are 2 theories about it. I will just skip this slide, right? But this slide is important for you to understand the incretin effect. अगर हम वैसे ग्लूकोज पानी के जरिए लेते हैं तो उसमें हमारे जिस्म से हार्मोन रिलीज होते हैं जो कि इंसुलिन की सिक्रीशन को बेहतर करते हैं, उसको हम इंक्रेटिन कहते हैं. अगर आपको इंजेक्शन लगे ग्लूकोज का तो कोई इंक्रेटिन रिलीज नहीं होगा, right? And this has a huge impact on our system. So somehow in diabetes, you get the irregularities of all these things. And this is important for us to understand. अभी जावेद अकरम साहब बात कर रहे थे that the insulin, there are many ways of stimulating insulin, right? So that's why the insulin is disappearing. And similarly, in surgery, there are many ways of stimulating the same insulin. And nowadays, based on these small drugs, which he's talking about, the GL3 receptor agonist and stuff, now we're talking of that we can give the metabolic surgery in a pill, right? So these small bursts, where you have to lose about 5 to 10%, this is called metabolic surgery in a pill. Now, primarily, you all remember the physician, the primary ABC goals in diabetes. A means A1C, it should be less than 7. Blood pressure should be less than 130 by 80. Cholesterol should be less than, LDL especially should be less than 100. These are the ABC goals. But the data have suggested that we are not able to achieve these goals in more than 50% of the patients, despite the best medications, and still with unacceptable high mortality. So we need to find some alternative treatments, just not only rely on the medicine. And the alternative treatment is surgery. All right, so we have data that when we treated these obese patients, right, obese patients, those who had diabetes, their diabetes disappeared, right? And now we have so many level 1A evidences, so many meta-analysis, Bookward, JAMA meta-analysis. There are so many meta-analysis. I don't have to tell you that it is effective, right? So these are two common procedures. I will not go into detail of those because it's really technical. But let's go to see the level of evidence. So there are so many randomized controlled trials. Now we have done the meta-analysis of those trials that for obese diabetic, bariatric surgery is the best form of metabolic surgery, right? And this is a famous Stampede trial in Ring Road. We have 5 years data. 5 साल तक हमने follow किया. We have seen that as compared to intensive medical therapy, surgery is still the best form. It leads to remission in more than 60% of patients, and a cure means prolonged remission in more than 25 to 30% of the cases. Similarly, the Bookward and these whatever. So not only we are having a resolution of diabetes, but the co-associated other complications are also reduced. So I want you to give your attention to this one. Look at that. The risk of mortality from type 2 diabetes decreased, right, by 92% for up to 7 years. Risk of death decreased by 60% due to MI. At 12 years, gastric bypass patient had a low blood pressure and low dyslipidemia. So there is tons of evidence that not only your diabetes is corrected, but associated comorbidities are also corrected. Now, while we are treating these, in 1995, there was a paper from US, Dr. Walter J. Porres, and his data showed that many of his patients who were obese, basically, they had a resolution of diabetes and hypertension, and people thought, if the bariatric patient can get rid of these diabetes, well, how about those who are non-obese, right? Let's just start thinking of that. Can we use the bariatric surgery for those patients who are basically low weight or non-obese category? And mind you, when you come to Asia and Pakistan, you will see that we'll have, even with the low BMI, we have very, very high incidence of diabetes and very, very strong brittle sort of diabetes. So there was, all of a sudden, there was in the literature, everywhere, in the magazine, in the media, for the last 15 years, this buzzword, the metabolic surgery, has been introduced, and everybody is now talking at this buzzword, metabolic surgery. When I did a fellowship, we never heard the name of metabolic surgery. It was all bariatric surgery or weight loss surgery. But now there's a specific name for bariatric and metabolic surgery. American Society of Bariatric Surgery changed their name from American Society of Bariatric to American Society of Metabolic and Bariatric Surgery. So we know that only weight loss, like, alone is not responsible for. There are other mechanisms, right? And just see, I put those mechanisms up there. So the diabetes resolution in such patients is independent of it. Yes, weight loss is a good mechanism, especially for obese, but there are other mechanisms which you probably are not knowing, but they are postulated as. These are those mechanisms, 1, 2, 3, 4, all are mentioned here. So this means that if you do some alteration of your gut anatomy to get some metabolic benefit, this is called metabolic surgery. And we have been doing this. The treatment of ulcer disease, the APD, was basically we're doing truncal vagotomy to basically reduce the incidence of peptic ulcer. And this has been done for the last 70 years or so. Right? So we've been doing it. We tried to treat hyperlipidemia by doing an ileal bypasses, and we failed. So the concept was there, but this advent of this laparoscopic surgery has revolutionized both bariatric surgery and metabolic surgery, and that's why it has been commonly used most of the time. So how does metabolic surgery works in diabetics? So there are two theories about it. Through Francisco Rubino, they did a study on rats, right? So there are rats which they can only become diabetics, and there are rats which can become normal. So what they did a gastric bypass, a gastrojejunostomy one, in which both the rows were patent. The food was also going through this as well as this. So this is a simple gastrojejunostomy. And then they did an exclusion, like we do it in a gastric bypass. The duodenum was totally excluded, and the gut was basically united down the stream, right? And they saw this, that when the gut was excluded in diabetic rats, their diabetes got better. Whereas the same thing done in normal rat basically had a problem. So that led to the theory that this diabetes is an intestinal disease, and by just altering the anatomy of the intestine, we can treat this. So पहले हमारा ख्याल था कि ये pancreas ही है, pancreas को हम ना आगे बढ़ा सकते हैं ना पीछे कर सकते हैं. But insulin secretion जो है, there are many other mechanisms, and there are hormones that stimulate को हम incretins कहते हैं. So there are many incretins जैसे GLP-1 है, PYY है, GIP है, और भी hormones हैं जो कि secrete करते हैं. तो अगर आप gut की anatomy को alter करें, so now we believe that diabetes is an intestinal disease. And these are the mechanisms. One theory is the foregut. The foregut के अंदर anti-incretin है, वो dominate करते हैं diabetics में, right? और somehow the other, अगर food का touch इनकी anti-incretin के साथ ना हो, तो incretin को ज़्यादा मौका मिलता है. तो GLP-1 वाला ये progress कर जाते हैं और sugar ठीक हो जाती है. दूसरा mechanism है hindgut. वो कहते हैं नहीं, जो आपकी खुराक जाती है direct ileum की तरफ, that creates a mechanism where, because GLP-1 cells are basically present in the ileum. So ileum में उनकी secretion बढ़ जाती है और उनकी synthesis बढ़ती है, इसलिए that's the reason. So either way, either we believe in foregut theory or we believe in hindgut theory, you can manipulate the intestine to produce the required result for diabetics. Now, coming back to, is it safe, effective? तो है, हमने देख लिया. We have a clinical evidence for that. सबसे बड़ा सवाल आता है कि अच्छा ये safe नहीं है, बंदे मार जाते हैं. That's why I totally believe that. कि अगर आप trained नहीं हैं, आपने exposure नहीं देखा, patient selection poor है, post-operative management problem है, because every intervention अगर आपको injections भी लगाएं किसी को, तो that can kill a patient, right? So for that reason, every intervention has some problem. But this intervention, let's see whether it is a problem or not. So हर बंदा कहता है diabetics पे ऊपर operate नहीं करना चाहिए. ऐसी ना? But let's see the data. So this is the data from Cleveland Clinic. This is the patient who were diabetics, and we operated on them, right? So you must have surgeries हुई हैं. Look at that. The highest mortality is the cabbage, and the lowest mortality is the laparoscopic bypass. All these patients were basically dead. Even the lab coli done on a diabetic patient had a higher rate of mortality. So this is safe. We have evidence that this is safe. It's much safer now since the advent of this Pakistan Society for Metabolic and Bariatric Surgery. People have large number, there are more people who are trained, and they can provide you better services. The second question is very costly. We know that the bariatric surgery is not costly. At the end of the day, 5 years, 10 years, वो cost जो है वो even हो जाती है. So I looked into the literature and saw there is a 26 meta-analysis available on different economic evaluations done for metabolic surgery. And everyone proved that it is cost effective. It is initially costly. In the first 2 years looked like this has high cost, but for 10 years, 5 years and 10 years, it is much more. जो आपने दवाइयों का खर्चा लगाना है, injection, end organ damage, complication, they are much more safe. So lean diabetics के साथ प्रॉब्लम ये है पहले हम ये समझ लेते थे कि obese नहीं है, there is a ton of evidence, yes, even with the lean diabetics, it is safe, and these are the evidence. I will not go into that, and these are the common procedures we do. This is an important slide. So when I talk about remission, I'm not talking of the cure. What do you understand by remission? तो एक तो metabolic surgery हमने बताया जब आपकी intention हो metabolic disease को treat करना, intention is not the weight loss. That is metabolic surgery. अगर weight loss intention है, that's bariatric. What do you mean by remission? So for a surgeon, for us, remission is when your patient is off the medication and he has got normal A1C and normal fasting blood glucose level, and that should stay for 1 year. This is called complete remission. And prolonged remission, when the same things stay for 5 years. So there are patients in my own follow-up. I've been doing bariatric for the last 16 years now. In my own follow-up, I have seen patients who are totally, they are not using any medications at all. For those who are on complete remission initially, we recommend that they should be on metformin, right? They should not, other statins later, that they should also be on statin. अगर ACE inhibitors ले रहे हैं तो they should also be certainly इनको withdraw नहीं करना चाहिए. But remember that periodically आप देख लें, they can be off from these medications forever. कुछ prerequisite है. Not everybody is basically fit for, and not every type 2 diabetes. You know there is a late onset type 2 diabetes, type 1 diabetes in type 2 diabetes. जिसको हम there's a clarification बड़ी सारी और कैसे हम clarify करते हैं usually by doing these antibodies level, right? So the two things which we do are essential as a workup is a beta cell function, here with the C peptide levels kitne, right? And then whether the antibodies are absent or not. So that was Caucasian data. What was the Asian population, right? आपको पता है India, Pakistan, Bangladesh, this South Asia is called the diabetic capital of the world because maximum population diabetes is यहाँ पे, right? So what is the difference? WHO ने हमारे जो BMI के क्राइटेरिया है वो भी चेंज कर दिए, राइट? और आप ये देखिए क्लास 1 ओबेसिटी इज 25 एंड अबव अप टू 30, राइट? ये हमारी क्लास 1 ओबेसिटी, राइट? बट I want to basically gain your attention on this one, the YY paradox. Anybody knows what's the YY paradox? There was a famous paper published in Lancet, the YY paradox. There were two physicians, one Indian and one Caucasian, the British physician, right? एक Jasnik और एक Yadnik, दोनों के नाम भी बराबर बराबर. But they measured their BMI and everything. So the BMI was same, 23. But the Indian origin guy had higher amount of everything. So he had impaired glucose tolerance, he had, so we Asians actually, with the same BMI, have double the amount of fat, have a higher risk of metabolic syndrome, cardiovascular diseases, and we have centimeters. So we are sort of an atom bomb. Despite look thin, but we are prone to, इसीलिए पता लगता है रात को फलाना बंदा सोया हुआ था और बहुत हो गया. So based on this 2016 data, there was a conference and there was a union of 45 organizations in the world जिन्होंने ये रेकमेंड किया और बाद में फिर एशिया में उन्हीं की एक रेप्लिका कॉन्फ्रेंस हुई in which they said that if you are a diabetic, right, and your BMI is 35, with or without, you must be having a bariatric surgery. When you do bariatric surgery in obese, right, for diabetes, it's still a bariatric surgery, but it can be called a metabolic surgery because the treatment is metabolic. And it should be considered for those with BMI between 35 and 30, that diabetes is a surgically correctable disease. You can both prevent and treat it with metabolic surgery. Thank you very much.